My name is Cray Bolger, one of the ultrasound faculty at Ohio State University. Today we will be discussing head and neck ultrasound. As with any exam, we will review indications, acquisition, interpretation, and medical decision-making. Given that this exam reviews a lot of anatomy and covers many exams that will extend across many scopes of practice, the indications are broad. They can include soft tissue for cellulitis or abscess, procedural assistance, ocular pathologies such as retinal or vitreous detachments, and thyroid masses. The scope of practice for each of these exams will vary depending on the provider performing the exam. To begin, with thyroid, we will place a linear probe in the midline of the neck and sweep inferior until we encounter the thyroid isthmus, this hypoechoic rim just anterior to the trachea. Once we see the isthmus, we will slide to the left and then fan from the superior pole to the inferior pole of the left lobe of the thyroid, and then we'll repeat the same procedure on the right side. It is important to interrogate the entirety of the thyroid from the superior pole to the inferior pole, looking for masses and irregularities. The thyroid anatomy is demonstrated here, with the isthmus just anterior to the trachea, the left lobe of the thyroid, and the right lobe of the thyroid tracking laterally and posteriorly. As we move lateral, the carotid artery will be visualized, and then the internal jugular vein. Just anterior to the great vessels is the SCM. If we are using this procedure to interrogate for landmarks for things such as a trach or a crike, we will rotate the probe with the leading edge towards the patient's head and then fan our probe or sweep our probe to the midline, looking to identify the cricothyroid membrane, the cricoid cartilage, and the tracheal rings. This can be helpful when we are unable to palpate landmarks and need to perform an emergent airway. Occasionally, we will see another structure just posterior to the left lobe of the thyroid. This muscular structure with a double layer wall is the esophagus. Here, the esophagus can be seen as the patient is swallowing and air and water are coming down it. Just to the midline from the esophagus is the trachea, anterior is the left lobe of the thyroid, and lateral is the carotid artery. Another structure we may want to visualize is the vocal cords. In this image, the vocal cords can be seen vibrating as the patient is humming. By identifying the vocal cords, we are able to real-time visualize an endotracheal tube as it passes through them. Some pathology we may encounter will be things such as a thyroid mass. The various appearances of a thyroid mass, whether it has calcifications, is hypoechoic, anechoic, isoechoic, or hyperechoic, may give the provider information about whether or not this mass is benign or malignant. To truly demonstrate the characteristics of this mass, however, a fine needle biopsy likely needs to be performed. Here are some examples of various thyroid masses. If you encounter these while scanning your fellow students, please get one of the ultrasound faculty to do a confirmatory scan and arrange for follow-up as necessary. Another pathology we may encounter in the head and neck is a peritonsillar abscess, or PTA. Here we can see the tongue base, the tonsil, and an anechoic center within the tonsil. This is your peritonsillar abscess. The great vessels can be visualized just deep to the tonsil. This exam is being performed using an endoluminal probe placed inside the patient's mouth. The great vessels are probably the most commonly interrogated structure in the head and neck. To do this, we will again use a linear probe, typically with the leading edge towards the patient's left, as this will ensure consistency when performing a procedure. The most common reason to interrogate the great vessels is to perform a central line into the internal jugular vein. What we will do is start at the head of the SCM and sweep down towards the clavicle to interrogate the IJ from the most cephalad to the most caudal portion, compressing the IJ intermittently throughout this interrogation to ensure that there is no clot and that the IJ is patent. The carotid artery can be seen here, just medial to the IJ. Typically, we will have the patient turn their head contralateral to the side we are doing. In this image, the provider is scanning the patient's right IJ. However, the image on the right is demonstrating the left IJ. Just to review some anatomy, the thyroid will be medial, and then moving lateral, we will see the carotid artery and the internal jugular vein with the SCM just anterior to it in the near field. If you are unsure what you're looking at, you may place pulse wave Doppler over the vessel to determine if it is arterial or venous. The carotid artery, as seen on the left, has a triphasic waveform, versus the internal jugular vein has a venous waveform with respiratory variation, as demonstrated on the right. If your patient's IJ is extremely collapsible secondary to position or dehydration, you may have them Valsalva by bearing down, and that will increase the lumen of the internal jugular vein. Things we are looking for primarily are clot. Clots can be hyperechoic, hypoechoic, or anechoic. Thus, it is important not just to sweep the vessel, but to also compress the vessel. Lastly, we will review ocular ultrasound. For this, it is important to ensure that your exam type is set to ophthalmic. The reason for this is it lowers the MI and TI and thus decreases the theoretical risk of damage to ocular tissue. As you can see in the image on the left, the provider is braced on the superior orbital rim. You may be braced on the superior or inferior orbital rim when scanning. This is important as we want to apply as little pressure as possible to the eye when scanning the patient. What we will do is place the probe in the transverse region and identify the lens, anterior chamber, posterior chamber, and optic nerve. We will then have the patient look left to right with their eye closed to look for any pathology, primarily in the posterior chamber of the eye. Most of the pathology we are looking for will be hyperechoic, so it is important to increase your gain. When performing this exam, you may use Surgilube, which is sterile gel, or you may place a Tegaderm over the patient's eye to decrease the incidence of gel getting in the eye. Let's review some basic ocular anatomy. The cornea will be in the near field and slightly hyperechoic, with the anterior chamber just posterior to it. The hyperechoic line behind the anterior chamber, which will often have a divide within it, the pupil, is the iris. The lens will be a circular structure where we will only see the posterior aspect of it, just posterior to the iris. The vitreous is the large anechoic space that makes up the posterior chamber just behind the iris. And the retina, which is typically not seen unless pathology exists, will be in the far field here. The optic nerve will be this hypoechoic just posterior to the retina. When pathology such as a retinal detachment exists, we will see movement in the posterior chamber. Here we can see this nice hyperechoic line that wiggles as the patient looks left to right. This is a retinal detachment. When looking for the retinal detachment, it is important to also identify the optic nerve to see if the retinal detachment is macular sparing or macular involving. Vitreous hemorrhage or detachment can appear similar to a retinal detachment. However, usually it is less dense and less organized. Vitreous hemorrhage will appear as hypo or hyperechoic material within the posterior chamber that swirls around as the patient looks left to right. This has been described as dirty laundry in the washer. A final pathology we might see is lens dislocation. This is when the lens, which typically resides up behind and within the iris, subluxes into the posterior chamber, as seen here. In summary, it is important to understand your anatomy when performing head and neck exams. It is also important to understand how to differentiate between arteries and veins with maneuvers such as Valsalva and pulse wave Doppler. When scanning the thyroid, it is important to interrogate in entirety from superior to posterior of all the lobes, and if any heterogeneity is seen, to note this and arrange for appropriate follow-up or biopsy. Make sure to use a linear probe when performing the exams and use the appropriate exam type, such as ophthalmic, to minimize the bioeffects on the tissue. With ocular ultrasounds, more gel, sterile ideally, and little to no pressure is key. If you have any suspicion for a penetrating trauma to the eye or a ruptured globe, do not perform an ocular ultrasound. While this is a relative contraindication, it can cause further harm to the patient. Another important pearl for ocular ultrasound is the concept of stationary video. We keep our probe and hand still while having the patient look left to right.